you, Sloan. By the way, Wendy thought there were going to be 12 people here, so I just want to say that you did. Don't even laugh. So the turnout is really incredible, and I want to thank everyone for coming tonight to a place that's so special to me and to Sloan. Sloan, I'm so lucky that you're here for a little bit, and then it's off to bed for you, as we discussed. But this place has really been a second home to us. Sloan is 5 now and in her final year of the nursery school. And this place is just really the best. So I wanted to warmly welcome you before we get into introductions. So tonight we're going to discuss IVF and the stigma around IVF. And also, I really want to talk about some uncomfortable questions that people might ask if you're trying to conceive, such as, well, you have one child, some people don't have any. Side note, gratitude and grief can and often do coexist. And questions like, you're really upset, I see, trying to conceive, and it's all consuming, but maybe you should take some time for yourself and work out. Never in the history of exercise has a Pilates class cured infertility. And I will say, as someone who does Pilates all day long and nothing else, according to my soon-to-be ex-husband, I would know that Pilates really doesn't. It doesn't help
place on the Upper East Side.
It tones and it helps with bone density, but infertility not so much. So for those of you who don't know me, and I'm like looking around and I feel like half of you are my mother's friends, so thank you for coming. I don't know what she's paying you in, but thank you. But for those of you who don't know me, I am Brittney Sobel. I am a proud mother of one, a surrogacy attorney, and the founder of a family building company called It Is Sloan. And I had Sloan via surrogacy, and it was an emotional and isolating journey, and I didn't really speak about it much then. And I read a quote recently that said, I wasn't myself for months, and nobody noticed, and I really felt that. I was that girl, and in lots of ways I still am that girl, because after Sloan was born, I held on to the hope of giving her a sibling, just something we talk about very often. But life sort of shifted, and I am going through a divorce now, so the reality is that I may not be able to do that for Sloan, at least not right now. And that's really painful. That's grief, right? The grief of a family that you imagine but may never have. And through it all, community has really been everything to me. And the 92nd Street Y in particular has been a place where I can show up fully. As a mother, yes, but also as someone who's navigating grief and loss, but also love and healing. So I want to welcome you. And if you're on a similar path, I want you to know that you're not alone. Your pain matters. Your story is real. I'm here for you. I know I could speak on behalf of my co-panelists. They're here for you. The 92nd Street Y is here for you. And there is so much power in being honest about the hard parts. So thank you for letting me share mine tonight. And I'm going to turn it over to Katie.
Thank you. Well, that was so powerful. Seriously, Brittney, I think just having all of us here tonight is so special for so many different reasons. So I have my notes so I don't forget to ask the hard-hitting questions. But I'm so honored to be here tonight, and thank you for putting this together. And thank you to Liz for bringing me on, as always. Well, as we all know, I'm sure so many of you in this room tonight have either struggled with fertility yourself or have a loved one that has struggled with fertility, or you're a family member of someone who's sitting on the panel tonight. I know my mom is here as well. And as we all know, fertility struggles can take a toll on us mentally, physically, emotionally, financially, medically. So tonight, I'm so lucky to be joined by this incredible group of powerhouse women who are here to separate fact from fiction and help us better advocate for infertility community as a whole. So before we dive into the specifics, I want to start with the two of you introducing yourselves. And maybe after you introduce yourselves, say if you're a mom of one or a mom of two, and talk about that despite how common fertility treatments have become, why do you think it's still so hard for people to talk openly about them?
You're up.
Dr. Bayer.
So nice to be here. Thank you, Katie. I'm Dr. Ariel Bayer. I'm a fertility physician at CCRM in New York. And a little bit about me, I'm born and raised New Yorker, so 92nd Street Y is always been a very special place in my community, so I'm honored to be here. And I did my medical training here in New York at NYU for my medical school, my OBGYN residency, and then specialized in fertility and reproductive endocrinology at also here in New York at Albert Einstein. And so now I see patients in my office at CCRM for all things related to fertility and reproductive health, anything from fertility preservation, planning for the future with either egg freezing, embryo freezing, and also seeing those who are either already tried to start a family and are having any difficulties and struggles and are suffering from infertility, and also tons of patients who need to do assisted reproductive technology to build their families, either via surrogacy or donor egg, donor sperm, and all of the above. So I'm honored to be here today, and yeah, I can allow Elizabeth to introduce
And then
herself.
we'll go back,
Yeah.
Hi everyone, I'm Elizabeth Barron. I'm a licensed psychotherapist here in New York City, specializing in treating women across the reproductive lifespan. So in addition to having a private practice today where I treat women and couples and families struggling with what's called perinatal mood and anxiety disorder, I really have a passion for this niche that I treat, which is women in this perinatal time period. For those who don't know what perinatal means, it includes women that are trying to conceive, which like Ariel, Dr. Bayer I should say, includes miscarriage and loss and grief and termination and all sort of alternative paths to becoming a parent. Then I follow women throughout their pregnancies into postpartum and across motherhood. On a personal level, I'm a mom of 2. What else do I want to say? I live around the corner, so I also frequent the Y and just love this place. I just want to add I graduated from Columbia with my master's in counseling psychology and then went on to train at a place called the Motherhood Center, which really prepared me to be having really, really challenging conversations with women who were suffering during this time period as they were navigating entering motherhood, right? So that really prepared me for really the rest of my career. Honored to be here, thrilled to meet people I didn't know and work with those that I adore, and I'll pass it over.
I didn't mention I am a mother of 2
I know.
as well.
I'm verklempt.
I know there's so much I want to
I know.
say. I do have 2 incredible sons, and I think being a parent, and it definitely helps me connect to my patients in a way that, having gone through all of the things, and being a parent definitely makes me want to build families for patients above and beyond.
So, and I'm also a parent of 1 and 8-month-old, and I met Elizabeth when I think I was like 3 months postpartum, and I just kept hearing about this term, postpartum depression, which we all hear about, we all talk about, and we met each other in the gym, and I said to her, I'm having severe postpartum depression, or what I thought was. And she looked at me immediately, she said, it's not that, you're having intrusive thoughts, it can happen trying to conceive, it can happen once you have a child, we're gonna talk and we're gonna help. You get through this, and I just thank you so much for that because it's meant so much to me in getting through everything. But I want to go back to the question to ask all of you, even though we see so much on social media and we see articles about it, and it's so open, IVF now, why do you think it's so hard to open up while you're in it? I know it was hard for me. I was not able, I went through IVF as well, and I went through, before IVF, 5 failed rounds of IUI, and prior to that, a loss because of PCOS, which Dr. Bayer can speak on more of. But I couldn't talk about it while I was in it at all. Like, I couldn't talk about it till afterwards, and I had this public platform, and I remember feeling like you, like such a shell of myself, and I didn't know how to explain that feeling. And had I opened up earlier, I think it would have helped me mentally, and I would have connected more with people that were going through it at the same time. So, Brittney, let's start with you.
I think that's a great point. For some reason, and we'll get into this tonight, there's this idea that turning to IVF is somehow giving up. It's like taking the easy route, and it's really the opposite of giving up. It is courage, and it is standing up and saying, I want this so badly that I'm willing to subject myself to physical, emotional, financial, social pain sometimes to do it, to have the possibility of doing it. It's not even a guarantee, right? So I think that people are ashamed of admitting that they turn to medicine and science, which is kind of crazy when you think about the shame. because they feel like they should have done it on their own, or it was, again, like the easy way out. So I think we really need to reframe the way that we speak about alternative methods of family building and IVF and other methods of having a child.
And something that I remember thinking when I was going through it was, unlike other illnesses, when you hear someone have cancer, or you hear a Lyme's disease, anything really, you think like, oh, that's happening to me. Like those are things that came out of nowhere that happened to me, I had no control over, where infertility, I found, felt so much more the opposite, where I'm like, something is wrong with my body. And I'm, doing all the right things. I'm philanthropic, I eat healthy, I'm so nice to everybody. Like, why is this happening? Why can't my body produce a baby? Something that I really want. And I think that's the disconnect between people sharing a lot of the times, because it can feel shameful. So Dr. Bayer, why don't you speak on that?
I think you both hit on such an important point of this, is that I know Elizabeth's going to speak to. It's a lot of grief, because you're already kind of sort of giving up the original idea of how you were going to build your family. So you have to accept that this is going to be a different way. No one, grows up thinking like, I can't wait to build my family with shots and a surgery. So it's like a grief or a loss in a way. And so you should.
I mean, it really speaks to, thank you for that, taking notes? Are we asking what's happening?
I think
who's going to win? Oh, there's a raffle or something, right? No, I'm kidding. You get a baby. Not funny.
You could talk to Jen about that.
So I think you're right. I have to comment on this piece about the medical illness and just sort of say what we all know in this room is infertility, in my opinion, is the most invisible illness to date, right? That people suffer from, that people who love others feel on behalf of them when in the park, right? This invisibility speaks to walking down the street and seeing bumps or strollers. And what you're saying, Dr. Bayer, that brings on the level of fantasy that we had about how our life was going to be with these kids, how we were going to get there. There's this, I don't know, what do you call this, a phrase like, or that old adage, first comes love, then comes marriage, then comes baby. And
carriage.
It's not that linear, right, for everybody. And I just want to point that out, right, that if there were more conversations like tonight, this is a perfect example of how to defeat the stigma truly, to be having open, transparent conversations with warriors, those who treat these warriors also, to really talk about the vulnerabilities and the ways that these women arrive in this time period. I even think for partners, right, when we go back to that first come love, then they don't even know what to expect if there is a partner oh, this is atypical, I wasn't expecting this either, so how can they even show up? So one thing I was hoping we could spend some time later on tonight is helping those in this room who love someone who's going through this with how to empower you with language, with understanding about what the person is suffering with that you love, right? Because if we can share vernacular in this room, right, about what these real experiences are, I think we're going to help raise much more resilient families and those that are proud of the struggle, which I know is nuanced, but I really do see that ultimately, people who become proud of what they've been through,
Well, it's definitely an invisible illness, like you said. I remember when I first shared that I was pregnant, and I shared it with context of it took me a really long time and a hard time to get here, and the amount of friends and just people that I personally follow on social media that responded to me saying, oh, I went through that too. Oh, I had to do multiple rounds of IUI too, or I had a loss, and all I saw from them and their pages, right, like Instagram and Facebook as a highlight reel, was the pregnancy announcement or the birth of the baby. I would have had no idea they had gone through that, and I think that's where something shifted in my brain, where it was like, wait, I have to really share this and encourage other people, because if you're like me and you're just scrolling, on social media all day and seeing all this happiness, and listen, people do get pregnant naturally all the time, I think you have to make it just as common to know that people also don't.
Yeah.
And I don't think that there's more people suffering with infertility. I just think now people are trying to share it more. Because that's also a question I have gotten a lot. Like, is everyone dealing with infertility now? Or are people just sharing it more? Do you want to answer that?
Well, I think that hits the nail on the head. The conversation and sort of the way we frame it has definitely shifted. No one talked about this if we were here even 5, 10 years ago, to have these conversations, these transparent conversations, and make everyone know that they are not alone, and they don't have to go through this alone. They can talk to friends, they can get support. They'll find that so many people around them have gone through similar experiences. Yes, we are seeing that women are delaying childbearing until older ages in their 30s, and the average age of childbirth, especially in New York City, where where we all live, is definitely increasing. So that with advanced age comes you're using older eggs. Your egg quality is going to decline. This is something that no one ever teaches us in our health class or in high school, or we don't ever learn that our eggs are a finite number. They're constantly declining, and the quality of the egg goes down as well. So what does that mean? And when you are trying to get pregnant on your own in your mid-30s, late 30s, even early 40s, you're going to suffer from more miscarriages and losses. There will be more abnormal pregnancies. It will take much longer to conceive. So yes, this is definitely because of the changing average age of childbearing, we are seeing much more infertility.
And we're going to get a lot more into the medical aspect of it later on, because I have a lot more questions on that for you. But I want to go to Brittney. Can you walk us through more of your IVF and surrogacy experience and how you dealt with the emotional toll? You said you were a different person and not a lot of people notice. How do you deal with that and then come out to be this powerhouse woman that you are today?
Thank you. I don't think I'm a powerhouse, but thank you.
You put this whole event together.
Thank you. Yeah, so I had Sloan via surrogacy at a time when really no one was talking about surrogacy at all, and I didn't know anyone who used a surrogate other than Kim Kardashian, who wasn't answering my DMs on Instagram for some weird reason, and not the most approachable either. But yeah, no one was speaking about surrogacy, and I didn't know anything about it, and I was kind of embarrassed to ask around, so I just deferred to my reproductive endocrinologist at the time, who told me, this is the agency that a lot of people use. Didn't do my due diligence, just went with that agency, and it ended up being a nightmare. It took us a really long time to match with a gestational carrier. We matched. I had gestational carriers who ghosted me before that was even a thing, went missing in action. Wow. So it ended up taking us 2 years to match with a gestational carrier, and I became so desperate to match that I ended up throwing away a lot of my requirements, and I matched with someone that I would have never matched with, honestly. She didn't meet most of our requirements and wasn't the best fit. And so we transferred 2 embryos with my hopes of being pregnant with twins. I had always wanted to have 2 for a number of reasons. Some of them I'm not going to get into tonight, but was really important to me. And she was pregnant with twins, and I was so elated. God bless you. And then an embryo split in a very rare turn of events, as you know, Dr. Bayer. It's less than a 2% chance of that happening. And my gestational carrier called me, and I was at work, and nobody knew that I was doing surrogacy. And she said, call me, I just had a routine scan. She usually just texted me, and I thought something's weird. Let me go into the bathroom. And she said, so I have good news. They heard not 2 heartbeats, but 3, and she was super excited. And I had very mixed emotions. I was I should feel excited because it's an extra child, and who wouldn't want a third child? But then quickly started to grow concerned when I spoke with my reproductive endocrinologist, who said, wait, this could be dangerous. We need to figure out what kind of pregnancy this is. And then unfortunately, we discovered that she was pregnant with triplets in a very medically complicated pregnancy. It was mono twins, and then a singleton Sloan. And she needed to have a reduction. So that was really painful also, because I felt I ought to be so grateful for having 3, but this could go terribly wrong, and we were facing a very grim reality of having 3 significantly neurologically impaired children if she had proceeded with the triplet pregnancy. So she had agreed contractually to reduce the pregnancy if it was medically necessary, and then she changed her mind. So that was interesting. She decided that she felt very connected to all 3, And she sort of left the reservation, started calling me a murderer, like you don't deserve to be a mother unless you want all three in whatever condition God intended for you to have them, and this is what God intended for you to have. I'm not going through the reduction. So it was a very terrifying experience, and thankfully in the 11th hour she did end up coming into New York for the reduction, and as a result we have Sloan. But it was a really emotionally charged and isolating journey because I wasn't speaking to anyone about it. I felt like no one really understood what it was like to go through an experience like this. And so then I set out, professionally to help people so that they didn't feel so alone, because I feel that connection really chips away at the stigma, and it's so important for us to connect and speak about these things. So yeah, that was my experience with IVF and surrogacy. And I actually, not to treat this as a free consultation, but I might. I did my egg retrieval when I was 28, and then I created, I think, half of them as embryos with my soon-to-be ex-husband. Also, shout out to my divorce attorney who is here. No, seriously, if anyone's having a marital issue, this guy, Brett Ward, Brett, I mean, he's here. How nice is that? But he is also, Brett, you know how I feel. I would not have survived the past 2 years without you, so thank you. But getting back to the embryos, they were with my soon-to-be ex-husband, and I had to discard those, which was another terribly emotional experience. So now I'm left with, I want to say 7. Who am I kidding? It's 7. I know exactly how many I have. 7 eggs. Yeah. And I'm 36, which, believe it or not, is considered geriatric in the fertility world. And we have to do something about that because that term is just awful. But yeah, so now I'm geriatric, and I don't, am I supposed to do another round of IVF? Because I would like to have another, and I've heard that you need at least.
Medical advances are so much greater now, too.
Yes.
Yeah.
Yes.
And all the legal stuff. Now you're up to it.
Yeah. So, I mean, yes, I'm not Brittney's doctor, but I do, in general, see a lot of patients who come to me when their relationships change and they're going through divorce, and they say, I'm not ready to have a child right now, but even if you have some eggs from when you were in your 20s, which hopefully are great quality, I mean, they made Sloan, and hopefully they'll do well. We don't expect all 7 of them to, 7 eggs, you have to know, doesn't equal 7 babies. There is an attrition rate when you're doing the process of IVF. And so all my patients, when I talk to them about the process of egg freezing, I say, I know you're not here for IVF right now, but let's talk about IVF, because these eggs, to make a baby, they're gonna have to be used in the process of IVF. So we go through the numbers and all the hypothetical numbers and the age that they were frozen, because yes, they stay that age for as long as you want to keep them in the freezer, but from the minute you take them out, there's already gonna be some loss. The good news is there's been such advances in our lab and our techniques. So the egg freezing technology we have today in 2025 and even the last 10 years is vastly different from when this technology was first starting out. And it got a bad rap because the survival rates of the eggs were not good. It's really come such a long way. We have a whole different technique to freeze our eggs now. And so that a majority of them, hopefully, when you come back to use them and you take them out of the freezer, ideally over 70% of them should survive the thaw. And this is 70% is just a very blanket general number we say for all decent clinics across the country. You really should look into your individual clinic and ask, what are your egg thaw rates? Because at a very good clinic, not to name names, but we're very proud of our lab results. We see consistently 85 to 90% or even higher success and survival rates of our eggs. And it all has to do with the magic in the laboratory and how amazing those embryologists are. So we talk about that process of what that would look like, what it takes to create an embryo, right? Once you fertilize an egg, egg. Not all of them fertilize. Once they are incubated in the lab for a whole week long, not all of them make it to the embryo or blastocyst stage. And then I highly encourage most of my patients, almost all of my patients, to do genetic testing of those embryos, and we can get into that. But only, a portion of those will be viable for transfer, and that's very age-related. So yes, numbers, more is better. Doing it at the youngest you can, doing it now, even if you're not ready. It doesn't guarantee any babies. It doesn't guarantee that it's going to work, but it gives you options for the future that you wouldn't otherwise have. And so I always talk to my patients about having a little bit of a head start or a leg up if they come back to do IVF in the future.
Okay, so Elizabeth, for so many, the experience of infertility, as we know, comes with isolation, shame, pressure. I know we have both felt that here. So when a patient comes to you, how do you even begin to dismantle those feelings? It's a big one.
So I do want to say that Brittney and Katie specifically happen to be really confident, resilient women, right? And not everybody feels that they have the same sort of ability to feel empowered to go out into the world and to share and to look for help. And so often when they make their way to my office, they're either depressed, anxious, hopeless, fearful, beyond overcome and overwhelmed with sort of this reconciliation we were talking about between fantasy versus reality. And so one of the things that I'm doing first and foremost is orienting them to this being perhaps the toughest season they've ever been in their life to date, right? And so in my office, we're doing, this is the office to get all the information. My office is the one to hold a hand, get a hug, feel less alone, truly know they're in it with somebody else who actually understands and has been in their shoes, right? And is nothing they say is too big, no thought they have is too scary. They really can sort of lower their shoulders and just be who they are, also outside of this fertility sort of world that they become embedded and enmeshed in, right? And so we're working on a ton of coping mechanisms. In addition, I'm not going to just say we're hugging in my office, right? We do a lot of that too, but there are modalities called radical acceptance, right? These are ways that we're helping women truly tolerate incredibly distressing emotions, things that they feel they can't really tolerate before, or that maybe people in their family can't understand, don't understand. The other thing we're doing is teaching patients about dialectical behavioral therapy, which is something Katie and I bonded over also. It's a modality of treatment called DBT. I'm sure people have heard of it, which again helps us tolerate not only distressing emotions, but diametrically opposing realities at the same time. So I'll use a non-fertility example. I'm thrilled to be here, and at the same time, moved mountains to be here with my kids tonight, right? And so same with fertility. I am so devastated, and I can find this much hope. Both things are true. And often what we think in our society is emotions and experiences are black and white. I only have to be happy and walk down the street or post all good stuff on social media and curate it. Or I could be really honest about the wide range of emotions that I'm experiencing that maybe people don't see, right? There's the invisibility again. And so again, teaching not only patients, but then empowering them to go out into their communities to find connection, right? Someone who's walked in their shoes. We call this a benchmate, something I'm working on the side. I'm gonna get some help. Some technology to help match people who are truly struggling with the same season of life. So if anyone wants to help, come up after, because I need help. And in addition to that, though, it's also giving them the confidence to go into their lives with their families and set boundaries and give language, right? So today, for example, I asked permission with this patient if I could share this story. We spent 45 minutes talking about Mother's Day. And, she's on her 4th failed IVF transfer. It's been 2.5 years. She's had every opinion in New York. And we're sitting with, that day, right? I argue it's 365 days of the year, the pain that these women are experiencing. But of course, Mother's Day is not easy. And so our work was less how do you feel about it? And was more, can you pass the diner? What's it going to be like to walk down the street? Maybe we should call your mother-in-law and request her to bring bagels upstairs. And it can be that concrete to help these women gain some control and feel like they have a sense of themselves back, right?
I think the part about two things can be true at the same time is so helpful. That really helped me going through infertility and also, being a new mom. My mom is here, but I remember her saying to me, you're going to probably be embarrassed, but while I was going through infertility, I was on Clomid, I was on all the things, and my mood swings were wild. And I'm pretty positive typically, so I think that the attitude I was showing and the demeanor was very out of character. And I remember you saying to me, like, is something wrong in your marriage? I only had been married a year, and I'm like, I love my husband, but I also hate him right now. Like, he can't get me pregnant, you know?
But yeah.
And I was like, okay, both can be true. I'm so happy in this relationship, and I chose the right partner, but I also want to kill, and I want to kill him because he can't get me pregnant.
Well, yeah.
or it's, even though it was my issue.
You remember when we bonded, I said to you, so no more either or. It's both and. And I take that home with you tonight. And by the way, practice it with your kids, right? It's like, it's not, did you have a good day? Yes or no. It's like, well, in the morning I had a nice breakfast, then I had snack, then I liked roof time. We have to teach kids that we experience a million things all at the same time. That's a human condition to feel complex emotion. And so you love Brian and you felt resentment. I mean, same, right?
Yeah.
And I just think it's such a hard thing for women to tolerate, but specifically with fertility, I ask women to practice in my office. I'm so overwhelmed, and I can do this next retrieval, right? I'm so hopeless, and I'm ready to fight. And not always, right? Of course, those are the reasons why therapy and group support, that's a big, Wendy and I were bonding before we started about maybe bringing some group support here too. I just see such a power and connection when women can practice this as a group. Like, you really get it. I don't even have to explain it, right, when you're sitting in a community. So that's another huge contributing factor to combating shame.
And just before we move off of this topic, how do you think social media has either helped or hindered people's feelings? Because it's not ever going to
So let's use the dialectic. Dialectic. Social media can be both incredibly empowering and educational and informing, and also totally dangerous and overstimulating and often triggering. And so I always say, let's actually, and I talk about that in the room, is it your time to go off? What's your state of mind when you open the app? What are you intending to do on social in this moment? Are you looking for someone like Katie Sands, who I think does a really nice job showing her delicious, if you've never seen him before, munchkin, this celebratory child that she fought for, and also acknowledging her pain that she went through. And so I think that's the kind of people. I'm all about cleaning up your, what's it called? Feed thing. It's hard. And I have seen people across the nation connect in what I call find their fertility buddy, right? I mean, there's someone in the audience who started a Facebook group, Fertility Friends of Friends. Fertility Friends. Perfect example where there's anonymity, right? For sure. So I think we have questions about shame. And at the same time, I think social can be so powerful in connecting you with someone you would have never been able to find at the local diner, right? So I'm mixed, dialectic, both.
I'm mixed too. I find when I was going through it, I couldn't find anyone that had gone through what I was going through. And I know now there was so many women, especially that I follow, that had gone through it. And I'm sure it's same with surrogacy. It's so hard. I really haven't seen anyone talk about it besides you. And that's also what gave me the impetus to talk about it, because I'm like, there must be someone like me who's going through it after that needs someone to go into a highlight and sit on the couch and watch Bravo and click on my highlights to make sure I'm answering their questions.
And something else you do great is you explain what REIs are, which, by the way, no one knows what perinatal is. No one knows what people look at me and they're like, wait, you sit with moms all day? That's a thing? It's like, that's a specialty, right? And it's niche. It's super niche. But
my parents still aren't
sure.
But
Mom, do you know what I do? You know what perinatal is. Yeah, she knows. My mom's here too. But I think that is actually one of my favorite parts about this panel is, as Brittney said, it was the first of its kind here. This is so new and nuanced, and conversations like this and taking it on the road and going into communities is really what's going to make the change.
I know Brittney and we've talked about this before, the barriers to care and the sort of hurdles that it takes to get to treatment. And then there's like the real ones, right? The access to care, maybe your insurance coverage, it may not just you're living in a geographic place that doesn't even have the physicians there. But then there's also that perceived barrier to care, and that's all the stigma, the shame, the fear of just reaching out to that doctor, making that first appointment, the fear of what your partner is going to think, what your family's going to think, and all of those expectations. So it's
Well, that was my next question, so you've already touched upon it, but how do you get people in the room? That's always been my biggest thing. Now, having gone through it myself and, doing it to have a baby, I have so many friends who are single, who are now in their 30s and might not be at the gestational age yet, but I want to say to them without being rude or sounding nosy, like, you should go freeze your eggs. Had I known what I knew, I would have done it too.
Yeah.
And now so many companies are also covering it, which is really incredible.
Yeah, absolutely. I think the most important thing the message to send out there is the initial consultation, like just that making that first appointment. You do not have to necessarily be like ready to start treatment or about to just embark on a fertility journey. It's just about education. And I think one of the biggest barriers to care we haven't talked about is education. We don't learn in our teen years in our high school health ed classes how reproduction works. We know how not to get pregnant. We're taught contraception and STD prevention, but no one ever goes into what it takes to actually make a baby, for that sperm and egg to find through the millions of it's so not talked about. And so what I do in my first visit with my patients is really just educational. I want to learn all about them, get their history, get their background, their family history, ask them questions so detailed that their GYNs probably don't have time to get into that, and just talk about what are their goals, what are their plans, and how does this all work, and then from then on decide what's a good plan from there. But making that first appointment not intimidating and scary, and you don't have to have tried for 12 months. You don't have to, have had miscarriages to come in.
And I know you touched on earlier the advancements in IVF. Like, what are the main ones to egg freezing in IVF that you think, people with a platform should really be sharing about?
I would say the two most important things that come to mind, one, the freezing technology has changed so much. So the ability to freeze your eggs for the future, it's as long as you are at a very good clinic who knows how to do IVF very well, who knows how to thaw eggs very well, that's of the utmost importance. So the freezing technology has changed, giving women options for the future, and also coming in younger. When women are using younger eggs, they just work so much better to make embryos. And then secondly, I would say is the genetic testing of embryos was really, it wasn't experimental. It's been around now for 15 plus years, but it allows women at all ages to know which of their embryos are genetically viable or have the correct chromosome count. So while some places will say, oh, you're young, you don't need to genetically test your embryos, I feel very strongly that genetic testing is important because it will allow you to at least give yourself, we talk about maximizing success, maximizing your chances of a baby. The time to baby will be shorter. You may not suffer a miscarriage or go through the emotional and psychological trauma that a delay in treatment or a failed embryo transfer may bring if you know that you're at least working with a genetically sound embryo. So I'd say the technology of genetic testing.
It's really so fascinating. I find it so cool. So as a surrogacy lawyer, how do you connect with the facilities to get people to you? Like, if someone had said to me, someone has said to me, I mean, my father-in-law's a perinatologist, that, you had a preterm labor, surrogacy is something that you should potentially consider. I wouldn't even know where to go for that.
Yeah.
So how do you connect?
No, that's a great point, and this is a pain point that It Is Sloan, my new company, is really trying to fix. The fertility space is so fragmented and vertically siloed. You're almost like a ping pong ball. You go to a reproductive endocrinologist, and maybe it turns out that you have endometriosis, let's say, or Asherman's, and that doctor doesn't specialize in that and says you need to find someone who does. You don't know really where to turn. Or if you end up needing a surrogate, you're asking a friend to ask a friend what agency they use. There's no really one person to hold your hand from start to finish. So we are hoping to fix that soon. But most of my clients come from referrals and word of mouth. But yeah, it's a real problem because people don't know where to go. And often you have a lot of unrelated third parties with conflicting interests, often monetary interests. And so you don't know who to trust either.
And I'm sure politics doesn't help. Like, states are shutting this down. Different surrogates can't be in certain states. I know I have a few friends who are gay couples who are having a really hard time even finding a surrogate in New York State alone.
Yeah, no, it's a tricky landscape for sure. Something a little bit off topic, but to meander back to the social media point, I think you absolutely do an excellent job with your social media posts on fertility. And something that was interesting that we spoke about yesterday when we were just running through things was you said that when you shared, you felt like there were a number of people who said your IVF story like wasn't enough. It wasn't bad enough. And that's something that I experienced also. Like, it almost felt if I didn't almost bleed to death while giving birth to a stillborn, or did 20 rounds of IVF, like I almost felt embarrassed to share my story. Like it wasn't horrible enough. And I think that's something that we really collectively need to fix. Everyone's pain is real, everyone's story is real. It doesn't matter if you've done one round of IVF, didn't do any IVF and got pregnant on your own, like that's amazing. But this shame around like how bad the journey was, it's really awful.
I always say any statement that starts with "at least" is problematic. At least you have slump. Well, so when we had coffee, right, a couple of weeks ago, just talking about this, remember we also shared this, at least you have slump. So you'll be fine. That's invalidation, right? And minimizing. And so my piggyback is no wonder people don't share. No wonder people keep their grief and their angst and their sadness so close, because it can often not feel so good to get back that kind of reaction.
Yeah, I mean, I think I definitely felt that when I had my first pregnancy loss. People said, well, at least you can get pregnant. Well, I'm like, well, there's something else going on. I can't sustain the pregnancy. And I think that people always, like you said, we talked about this yesterday in depth, but people always want to have the worst version of your story, right? Especially when you share anything. They say, well, you got pregnant on your first retrieval. Well, I had to do 7 retrievals or transfers or something like this. And not everyone's story has to be worse than the other. Everyone can hold space for whatever you're going through and what your truth and story is. And I agree. I do think it's why some people maybe don't share, because they 100%. Think, oh, I got pregnant on my first IUI. Yeah, I should be grateful. It's like,
instead of maybe bonding or connecting over the those ultrasound texts, that's the scariest morning to wake up and have an 8-week scan. Like, because those 2 women who you're saying, 1 lost versus 8, experience that same worry. And so, again, dialectic, right? Both things are true. You can both have different stories and still connect, right?
So Elizabeth, how do you help family members who have a loved one going through infertility or a partner? I think that's something that's, sorry to the men, but I think men very much struggle with this. I know my husband did, because it's happening to the women. I mean, men can have infertility as well, but most of the time it affects the woman. So how do you handle that? And where do you even start?
I love bringing partners in. First of all, it's actually some of my favorite work is working with partners who are like, I've never done this before. Are you going to make me talk about my feelings? It's like, yeah, you have them, right? So let's go back to the at least. We're teaching family members to not say that, right? It's just so invalidating. The other thing we're doing with family members and partners a lot is teaching them how to listen without fixing. I mean, it sounds simple here, but it's really hard for someone when you see your loved one going through pain. And someone might be like, what's that mean? I'm saying zip it and sit and hold pinkies if that's the only way you can connect, because sex now means so many other things to the 2 of you, and really listen, right? And then people say, well, then what do you say, right? And it's like, I'm here, I'm listening, I'm going nowhere, right? So it's really bringing down some of this heat The other thing we're doing is helping partnerships have what's called a worry box. It's like my favorite coping skill is to give them 10 minutes in their evening before they watch a show or before someone takes a shower to have all the stress, all the tears, all the cries, all the questions, all the intrusive thoughts. And then I know it's hard to contain, but it really is a beautiful skill. When the 10 minutes is up, it's like, we'll come back tomorrow, right? And so it's not going away, but it's on a shelf, and it remains, and it exists. And we need to go back to the other parts of our lives, because these women struggling with fertility share like 7,000 other identities. Their daughters, their daughter-in-laws, maybe their mothers to toddlers, maybe they're doctors, maybe they're therapists. And so there's a lot going on in our minds. So helping them contain. The other thing I always say if a family member asks me how I can show up is I say something like, please don't offer quick fixes, right? Chill with your ideas. I mean, that's my non-clinical voice, but like, we get it. Like, let me tell you some examples. Are you eating blueberries? Are you doing Pilates? Have you tried acupuncture? Go on a vacation. Just relax is my favorite. And what I want to share with this community is like, infertility is a medical condition. It's not a mindset issue. And I really I feel like I have to say it again, like infertility is not a medical condition, it's a mindset issue. And so I know, especially for those sitting here who are again watching their loved one in pain, it's so hard to not come up with ideas and want to be practical. And that is sort of how we're taught how to help. Here, I have another idea. Or my friend had 5 miscarriages, so you should do what she did now because now she's through it. No two stories are the same. Be with your friend or your loved one or your person and wait to see what they need. And that's the last thing I want to say, is really helping us ground into this season, right? So what someone might need in a year from now is different than what they need tonight, this evening, after a failed transfer. Or perhaps, go ahead, sorry. Okay. So again, like helping people really get more intimate with themselves and their emotions in this season. In this season, I'm not up for Mother's Day. Like, it won't be forever, but today I can't go, right? So helping people and partners especially ask some of these questions to intended parent, like, what do you need tonight? How can I help in this moment? Rather than these big sort of long, it's very overwhelming to think about the whole pregnancy or the whole surrogacy journey, right? So,
and I do also want to add the men, there are, 50% of fertility cases can be male factor or genetic issue with the male or some of the sperm issue. So that is, I think, even harder too when a woman is going through all of this and their partner is the one that has brought them, into that journey. So I don't want to ever, forget that, and it becomes very complicated with how to manage, because men probably talk about their feelings.
no, but at the same time, I see so many partners then raise their hand. It feels so good, and they're like, can I have a therapist, Elizabeth, too? And that's the best, right? Is then they're on their own journey. I can take care of mom. We can empower them about make a list together, going into the doctor's office. I mean, I'm doing a lot of this concrete skills, right, with these patients who feel immense overwhelm. And then the 45 minutes a week, what I always say is it's only 45 minutes a week. And so I need you two together to do some of this at home, right? So.
And there are now medical fertility, men's fertility centers like Maze that really help the men as well that I had never heard of until
we have.
I was going through it.
A lot of fertility clinics will have like an in-house reproductive urologist. We work with really closely like 1 or 2 reproductive urologists for males. And that's just like part of the care team. I would say also with maximizing and optimizing your IVF journeys, it's all of these pieces have to come together, right? Like looking for the right agency, the mental health piece, the right clinic. You have to kind of build that team.
We're gonna do it together.
Yeah.
We're gonna do it together.
You've got a team.
And we could talk, I have a lot more questions, another page to go, but I know a lot of you guys in the audience have questions as well. So I think I'm gonna gear it towards the questions you guys have. So the first one, this is for Dr. Baer. What is optimal size of follicles for women over 40? Was told 16 millimeters to 19 millimeters. I don't know what this medical term is, so I'm just going with it. By one doctor and over 20 mm by another. This is regarding the trigger shot.
It's a really good question. So this patient or this person in the audience is just asking the most ideal time in the stimulation cycle to get those eggs to be ready for release right before the egg retrieval. So it's very dependent on the patient. Ideally, we try to grow all of those follicles above 17 or greater to get them to the mature phase of the egg cell cycle. But every person it's such an individualized care. So the good thing about, having your own doctor look and watch your cycle, if you've done a cycle before, knowing when your best trigger should be. So some women, they have a lot of mature eggs in 14 to 17 range. Some women will have mature eggs after they're already grown above a 20 millimeter size. So I think having a physician who really is just taking really good care to look at your own data, your own cycles, because there isn't like a cookie cutter one size fits all, and age is a factor sometimes. Sometimes for women in their 40s, we find that maturity happens a little bit quicker and earlier or smaller follicle size. So I would say, yeah, it's so individualized.
And there's another question. How do you know when to move on from your medical practice or provider? And this I just want to touch on quickly because I remember someone writing to me like they were very unhappy with the fertility center that I went to. And I remember thinking, you're always going to be unhappy. You're going to be unhappy with your doctor until you're pregnant, right? Like, it's the truth. And I feel like it's so sensitive for so many people, but they come there with a purpose to get pregnant. Yeah. And until you're pregnant, people are in a bad.
It's really hard. I mean, I've had patients who've like cursed me out on the phone and then come with their baby the next year, and they're like, "I'm Dr. Mary, love you, and I'm just so sorry that it's a really high highs and really low lows." But I do think getting a second opinion is never a bad idea. I see tons of second opinions in our office. So if you have a gut feeling, if you are not connecting with your clinic, with your doctor, if it's difficult to communicate, if it's difficult to reach them, if it's difficult to get a response or an answer from your clinical team, that might not be a good fit for you. We're very fortunate to be in New York City, and there's tons of options. But I think looking for a place, one that has a very reputable lab, a really high quality lab is of the utmost importance, but also having a doctor who's going to really listen to your concerns, your symptoms, is going to be on your team. And not hard to get in touch with. Those are all, there's a lot of reasons to get a second opinion. It never hurts to get a second.
I just want to add, right, because a lot of, again, the pain comes to the couch, right? And it can be like, I feel unheard, or I feel so rushed. Those are all good ones. Or I feel like another patient, right? But I think another thing can often be like, I feel like my feelings aren't valid or minimized. And so those are great, obvious, but often really hard because someone could be super, super brilliant, or they came so highly, or they got your best friend pregnant, or your sister-in-law.
And so deep into treatment that you're like, the idea of switching clinics is really onerous.
And use the dialectic. You can do it, and it's scary, right? Like, it's just another opinion. It's just to sit in front of another, and I say that about a therapist too. I'm not everyone's appetite. That's totally fine. And let's find you the right fit, because we care about meaningful care, right? We don't, I'll leave it at that. So.
Okay, Brittney, I think this one is for you. If using donor sperm, can you tell us about a second parent adoption and any other necessary legal steps to make sure that the parent who is not genetically related to the baby will be seen as a legal parent?
I'm assuming that this is in New York, so I'll answer as if it is. But it's relatively simple. It sounds more intimidating and scary than it actually is. But it's just, you need an attorney, obviously. Preferably an attorney who specializes in assisted reproductive technology. And it's just filing paperwork, really, before the birth, so that you are established as the birth parent on the birth certificate.
And I know you also mentioned before, it's a question I have, when you make embryos together, how did you decide to also freeze eggs?
I just said I'm freezing it. I guess I sort of knew that this was might end in divorce. Really, because who would do that?
Because I also love
children.
What?
No, we have patients.
But it's, no, because when I even listening to myself now, I'm like, wow, that was really telling. Yeah, because it is kind of awkward to say to your fiance or your partner, like, hey, buddy, some of these is separate because in case this doesn't work out. But
I always ask the patient in a separate room, not with the partner.
Yeah, but I basically, I didn't give him a choice.
Right.
Okay, the next question is.
And by the way, to that point, I highly recommend that you do that. If you, even if you're married, you really ought to take some, not half, but some, and freeze them separately as eggs, because over half of marriages end in divorce. So
I talk to patients a lot about that who want to split their cycle. It does depend on the number and their age. Sometimes splitting the eggs, I feel like you're giving yourself half a chance in both directions, because when embryologists are looking at the eggs under the microscope, there's no way to tell which are the good ones and which are the bad ones. So they're basically drawing an arbitrary line down the sand and saying, okay, these are going for the egg pile, these are going for the embryo pile. So I often recommend keeping that whole cohort together if they can do a second cycle. If they can. A lot of patients can't afford that. It's not covered. So it's a conversation to have with your physician. Yeah.
So interesting. Okay, the next question is, what type of donor sperm is best for IVF? ICSI, IUI, ART, IVF, ART, etc.
Oh, good question. So for donor sperm, if you're doing it for IVF, is that what the question was? So it so depends on the patient and their health and their fertility and their age. You can use donor sperm with an insemination. So this is intrauterine insemination, the acronym's IUI. So it's someone who has to have regular menstrual cycles, ovulates regularly. That's definitely a path to parenthood. You can do insemination. A lot of lesbian couples, young couples, couples who just need to use donor sperm but otherwise have no other fertility issues. If you're using IVF, we recommend ICSI, or intracytoplasmic sperm injection. It's a mouthful, a tongue twister, but all that really means is putting that sperm directly into the egg. IVF, I think I'm like such a nerd in terms of like Latin words and origins, but in vitro just means in glass fertilization. So the fertilization is in a glass dish. That's the way that IVF was first invented. The egg, the sperm, you pour it on, you let.
It's so good. They don't know that.
Yeah, I love in vitro. It's glass.
So and I read now that you can do IVF, and you don't have to. The woman doesn't have to do the 10 weeks of shots beforehand.
Oh, that isn't quite ready for prime time.
Okay.
But one day, I hope. Yeah, that's in vitro maturation.
I was like texting.
Yeah,
my
doing it
doctor,
outside the
being like,
box. That we hope to get there soon. Yeah, and it's in phase 3 clinical trials, hopefully coming soon. But in vitro fertilization, everyone says IVF, because that's how it was invented in the original days in the 1980s when those first babies were being born. But in the last 20 years, we've been using ICSI, or intracytoplasmic sperm injection, because we see higher rates of fertilization, less failed fertilization. Whenever we're using previously thawed frozen eggs, they have a little bit of a firmer shell around them, so we actually do need to inject the sperm directly in, so ICSI is important. And also when we're using older eggs from women who are, elderly or
I was gonna say
we hate
36.
geriatric. I mean, more geriatric than you. But advanced reproductive age is the proper term. We do at our lab and most labs across the United States use ICSI. So IVF, everyone says IVF, but we're really all doing ICSI most of the time. Most of the time, especially if there's a male factor issue, unexplained fertility. There are a lot of indications for that.
Amazing. Well, does anyone else have any other questions? Hi. Could you, John?
Is there any correlation that you see between girls that have been on medicated birth control too many years because they had PCOS or cysts and they stayed on birth control until 27, 28, and then they had difficulties getting pregnant?
So that is such a good question. I think that the birth control that many women go on in their late teens or put on, because they're getting irregular cycles or having bad symptoms as a teenager and stay on it for years and years, it's not causing infertility. The pill is a reversible thing. You stop the pill and it gets out of your body. It's a completely reversible, safe medication to take. But what's happening is if you've been on birth control for decades, and I have patients who come in all the time, I've been on birth control for 20 years, like what's gonna happen? They don't really know what their natural fertility cycles or their menstrual cycles are like. So PCOS, for example, will be masked while you're on the pill. The treatment for PCOS is the birth control pill. So you've been treated for years, you finally come off the pill ready to have kids, and all of a sudden you realize, wow, I have PCOS. So there's a lot of sort of uncovered diagnosis when women come off the pill, not caused by the pill, but just being treated or masked that whole time.
Yeah. I had another daughter, and I didn't, I always felt a little bit guilty because I did not have trouble getting pregnant, so I felt so badly when she was having trouble. We couldn't really, even though I'm very close with my older daughter, we couldn't discuss it at all. And the younger daughter has been on birth control also for over a decade, and I'm just looking ahead and wondering if there was any correlation, but now I understand what you're saying.
But I also have PCOS, and I went back on birth control while I was doing IVF, and it actually helped me get pregnant. So you go back on it so that they can track your cycles and they can plan.
We use
Yeah.
the pill in different ways. We absolutely will use the birth control pill at the start of cycles to time the IVF. So what while it's doing the birth control is keeping you in a very like suppressed, quiet state so that you can start on time. Or if you have an event, you have your life going on, and you need to do IVF at a certain time. We'll often use it as a tool for like starting your cycle. But yeah, it's not. We use it as a tool all the
And
time.
other things too, right? Progesterone, metformin, right? Like there's a lot of stuff you use to help
Yeah.
look at someone post birth control.
Yeah.
Do you guys have any last remarks you want to share before we close? Yes.
Hi. I don't have a question per se. Thank you, Liz, for plugging the Fertility Friends Facebook group. But I just had a few things that, as someone who's an IVF and a surrogacy mom, I think are also important things that you guys, praise, amazing. You hit on so many notes, but I think there were a few things as someone who's often on all aspects of sides that I just wanted to add. But you mentioned education is power, but I also think information is power. So the earlier you can get tested and just even know simple things like your AMH level, or maybe you have a thyroid issue, or you have hypothalamic amenorrhea and you would never know because you didn't go off the pill and you thought you had regular cycles. Any extra testing you can do, even if you're not ready, the earlier you do it, the earlier you know. I've heard stories of people who go in, they had no idea they had like 2 uterus. They never did like a thorough ultrasound. And a lot of times like your OB doesn't necessarily, you haven't tried for a year yet, don't worry, don't stress. And so that was one thing I wanted to mention, as well as we talked about second opinions, but really advocating for yourself. You're your best advocate. You know your body better than anyone. I always say, nobody's losing sleep over your case except for you. You have a question, you want to seek a second opinion, you want to ask. There's no silly questions, and it never hurts to just talk to somebody and just say, I was thinking, can we try this? Worst comes to worst is they say no, but you'll never know. Two other things, sorry. I think that another reason that people don't share as much is because there's no guarantee it works. Some people think IVF is like automatic success. And so they don't understand why after 2, 3, 4 transfers, you're still not pregnant. And so people think if they share they're doing it, they have to provide an update. And if the update's not good, they don't want to keep letting other people down. So I think you can guard and you can share what you want to share on your own timeline. And the last thing is for people who are supporting others who are going through it. I had some people be like, well, let me know if I can do anything. And like, what are you going to do for me? Like, I'm not going to ask you to do anything. So I say, don't ask, just do. Send flowers, send cupcakes, offer to take them for a manicure, pedicure, massage, just do something to let them know that you're thinking about them. You can even say here are some options of things I'll do for you, choice. Like you do for someone who's postpartum, and say I'll buy you groceries, whatever. I'll take your secondary infertility. I'll take your toddler for a few hours if you want some rest. I know it's been a long week. So.
Take your pick, right?
I think that's Ashley, that's great. Thank you for adding that. I think, to your point, we do such a good job as a society of gathering around our friends and family when they experience a loss, the death of somebody, especially as Jews, right? We go and we sit Shiva, but when someone is going through infertility or experiences a loss in that way, and the loss of a dream of building their family in a way that they had imagined, we're kind of silent because either we're uncomfortable, we don't know how to support them, or we show up in a way that is unwanted or unhelpful. So to your point, Ashley, I think just in a similar way to how we grieve the death of someone and say, you sit down, you take care of you, I'm taking care of the house, I'm coming over to clean, coming over to cook, whatever it is, could be really, really helpful.
Thank you for sharing. Ashley's amazing, everyone. You should follow her account on Facebook. But guys, thank you so much. This was really so powerful. I've learned so much myself. I hope you guys did too. We'll be around for a little bit.